Welcome, everyone. This is Kate Myers, Senior Program Officer at the California Healthcare Foundation. And for those of you who don't know CHCF, we are a nonprofit independent philanthropy based in Oakland, California. And we focus on improving the way the healthcare delivery system cares for the people of California, particularly those with low incomes and those not well served by the status quo. And I'm very pleased to be here today to discuss with you some results from recent survey work we've conducted to better understand Californians' attitudes and experiences related to serious illness and end-of-life care. And I'm excited today to be joined by Dr. Ann Kinderman, Director of the Supportive and Palliative Care Service at Zuckerberg San Francisco General Hospital, and Tressa Undum, Partner at Perry Undum Research and Communication, a public opinion research firm. Next slide. So a few housekeeping items before we get started. As you may have noticed, all lines on the webinar are currently muted. We encourage all of you to submit questions anytime throughout the webinar using the question and answer platform. Please only use the chat functionality if you're having technical difficulties, because that only goes to our host. This webinar is being recorded, and the recording and slides from the webinar will be available within a couple of weeks on the CHCF website. So our goals for today generally are to talk a bit about why we did this survey work, what we sought to learn, and describe how we did the work, what our survey methodology looked like, present some selected key findings so that you all understand a bit about what we found, and to talk about the implications of this work. What does this information and what we learned tell us about attitudes and experiences with serious illness and end-of-life care, and how can we build on this knowledge to continue working to improve care for people with serious illness? Next slide, thank you. I wanted to mention that today we'll be sharing some highlights of the results from the survey, but there's actually much more information and additional resources that can be found on CHCF's website at chcf.org/helpwanted. I've highlighted a couple of things here, and just to briefly mention, the main survey report is what we call a data snapshot that contains, again, key highlights from the report that we thought are most interesting and compelling for our audience. We also have two fact sheets which dive deeper into a couple of topics of interest. We also have full details on the survey methodology, the complete questionnaire, and top-line results to all of the survey questions available on the website. And I want to especially point out that we have 3 short storytelling videos which provide input and perspectives of patients, caregivers, and providers, including Dr. Kinderman, who's on this call today, talking about how serious illness and end-of-life issues impact them or impact their patients or have impacted their family members. And our hope really with all of these resources is that you go to the website, you explore them, you think about how you can use these resources to help others understand these issues better, and that you share these resources in your networks and tell others about them. Next slide. So just a bit of context before we dive in. Some of you might be familiar with the fact that the California Healthcare Foundation has actually conducted 2 previous statewide surveys back in 2006 and in 2011, focusing then on attitudes and experiences with end-of-life care. We found those surveys and the data that came from them to be very helpful to us as a foundation, and I think it's been helpful to others in the field to help us identify gaps and opportunities. As CHCF's work in this area has really moved upstream in recent years to focus on serious illness care, and as our organization has sharpened our focus to Californians with low incomes, we realized that the data we had was insufficient. We wanted to know more about more populations, including those with serious illness, and to be able to understand how the needs of Californians with low incomes may differ. We also wanted to explore, in terms of serious illness, how interested in or open to the types of services provided by palliative care respondents are. And of course, we want to be able to apply these learnings to improve serious illness care in California. I'll just mention that to get us started in this work, we did engage an advisory group that really helped guide us throughout the process. I just want to thank that group for their participation. It consisted of advocates and clinicians and researchers, some folks from health plans and health policy realm that really helped guide our thinking about what we should be trying to learn and why. Before we dive into the research itself, I've asked Dr. Kinderman to talk for just a couple of minutes about palliative care, because I wanted to make sure that we all on this call have a shared understanding of palliative care, as it's one of the key concepts that's embedded in some of our survey questions, and it's the underpinning for much of our work around supporting people with serious illness care here at the California Healthcare Foundation. So with that, I'll turn it over to Anne, and then we'll follow up with Tressa.
Great, thanks, Kate. So I wanted to acknowledge that I know that at least looking at the folks who registered for this webinar, there are many on this call who are very familiar with hospice, others who are very familiar with palliative care, and then probably a bunch who are less familiar. And so since we're going to be talking about these survey findings and the type of questions that we asked, we wanted to provide some context. And I think that when palliative care is said, a lot of different images probably pop into people's minds, but I really wanted to put this image in people's minds when they think about palliative care, that to palliate a symptom or a situation means to relieve. And that is what I'm hoping that people can hold in their minds, in addition to some of the words that we'll go through. So there's an organization, the Center to Advance Palliative Care, that has done actually a lot of work in talking with average Americans around how to best describe the concepts of palliative care, and there are a couple of key concepts here. So one, palliative care is a medical specialty that's focused on preventing, treating, and relieving the pain and other debilitating effects of a serious or chronic illness. And it's provided by a specially trained team that often includes different disciplines, but often includes doctors, nurses, and other specialists who work together with a patient's other doctors to provide an extra layer of support. And it's appropriate at any stage and at any age when you have a serious illness. And it's provided alongside curative treatment. So it's not an either or, it's a both and. And I will say that I use these words on a daily basis to describe what we do in palliative care. Another really helpful ad campaign that came out that was done by the Cancer Action Network to try to describe palliative care was this series, and talks about how the experience of patients a lot of times who are dealing with this serious illness is that they can feel like their life and their identity is consumed by their illness. And this picture really highlights that someone, cancer patient, is not just a cancer patient, they're a dancer, they have other identities that are really who they are. And that palliative care is really about the person and about helping them to live their lives and improve their quality of life. Another way to think about it is to think about what are the main domains of palliative care. So we say that the patient and their family members, the people who are around them, are the center of what we do. And then we have these 5 main focus areas. Important focus areas: symptom management, helping to relieve pain, shortness of breath, nausea, constipation, everything that comes along with a serious illness. We also provide information about prognosis when that's desired, and about the treatment options, so that patients really have the information that we have about what's going on and what they can expect. We spend a lot of time, perhaps the most time, speaking with patients about their values, their wishes, their hopes, and then we help create an individualized approach to medical choices based on that individual person's values and wishes. We spend a lot of time providing spiritual and kind of support around the existential questions that come up for people, like, why is this happening to me? What does this mean for me? And then lastly, something we'll talk about a lot on this call is the psychosocial support aspect. Serious illness affects many aspects of people's lives, whether they're able to work, whether they can get around and do the things that they want to do, would fall under psychosocial support. So with that, I will hand it over to Tressa to talk about the survey.
Thank you. So this is, again, Tressa Undum, a partner at Perry Undum. And before I dive in, let me just say thank you to Kate and the foundation for bringing us into this work. We're very grateful to be part of any research that lifts up the voices of people who tend to be underrepresented in policymaking. You know, especially tends to be lower income people, people of color. So we're really glad to be part of this project, especially on this important issue. So I'm going to briefly talk about methods, and then we'll get into some of the key findings. So as Kate mentioned, one of the focuses of the foundation and of this work was to really look at the needs, preferences, experiences of Californians with low incomes. So we started this project with qualitative research. We did 6 focus groups. We did 8 in-depth interviews in 4 different languages. Among diverse Californians with low incomes, everybody was under 200% of the federal poverty level to essentially make sure we're asking the right questions. So the purpose of this phase was really to inform the survey instrument. We tracked a lot of questions from 2011, and then we added and asked new questions based on this qualitative research that was conducted almost a year ago, late 2018. On the next slide, the main part of the study is quantitative and a survey, which was fielded this summer, about the month of June, among 2,588 Californians, adults 18 and older. We used Ipsos Knowledge Panel. Knowledge Panel used to be at GFK, and at one time it was called Knowledge Networks, if anyone happens to be familiar. This is one of, if not the most robust representative online panel in the country. They recruit panelists through address-based sampling in the mail. So you start with a sampling frame of 97% of households. If a household doesn't have internet access, they provide it. If the household doesn't have hardware to access the internet, they provide it. So it's a really robust methodology. There are flaws with every single type of survey research methodology. This one is no exception, but it's pretty robust, and this is the methodology we used in 2011. And you can see we have pretty decent cell sizes of respondents by income level. We broke it out by federal poverty level, by race, ethnicity, people with a serious illness, and Californians who've had a experience with a loved one's recent death. One limitation of this study, and frankly almost every survey that's conducted, is the constraints around interviewing Asian Pacific Islander adults in several different languages, and that's just something that the survey research field has not figured out how to do, because there's so many different languages. At least they haven't figured out how to do it in a way that's representative and does not cost literally $1 million. So that is a limitation when you see that data. These are English, predominantly English dominant Asian Pacific Islander respondents. So let's go through some of the findings. There's a whole lot more findings online. I'm going to give you some of the key findings. I'll start with some of the data that where we see some shifts since 2011, and then I'll talk about some of the findings that have remained consistent, and then we'll end with some of the new questions that we asked based on the qualitative research. So first, where do we see some shifts or change or differences from 2011? One area is awareness of terms related to serious illness and end of life. So you can see on this chart, the orange is 2011 data from our 2011 survey, and the blue is 2019. So across these terms, hospice care, DNR order, advance directive, palliative care, pulse, more respondents now have heard about these terms and concepts. And if you look, even the biggest difference, net difference, is with palliative care. There's a 20-point difference from 2011 to 2019. And even pulse pretty considerable change. I think in 2011, when we conducted the survey, PULSE was relatively new, so only 13% had say they had heard about it, and frankly, that's probably a little higher than what was really true. But now 22% have heard about it. So that's sort of a signs of progress, at least. On the next slide, and this probably isn't going to be surprising to people, but there is a correlation between awareness and knowledge of these terms and income. So the low-income respondents are least aware of every single one of these terms, except what's interesting is pulsed. So that bottom set, the proportion who say they've heard about pulse, there is no difference by income, and that suggests that recent efforts might be doing a good job of reaching low-income adults across all of these terms. But in addition to income, men are less familiar than women. That's probably not a surprise either. Californians of color are less aware than white respondents in our survey. But again, the exception is among PULSE, which is interesting. So on these other terms, white respondents are more aware, but among PULSE, it's pretty even across race and ethnicity, which again suggests that recent efforts might be doing a good job there. On the next slide, another difference we found from our 2011 survey is the proportion of respondents who say they have their wishes for medical treatment at the end of their life in writing. So 34% of respondents say, yes, I have these wishes in writing, compared to 23% in 2011. 61% of older adults in California, 65 and older, say they have their wishes documented in writing. So higher, obviously, than, no surprise, higher, probably could be higher. Compared to 2011, it was 54% of older adults, so 7-point difference there. White respondents and higher income respondents more likely to have their wishes documented in writing. So those are a few of the findings where we see a little bit of a shift and in a positive direction from 2011. On the next slide, the vast majority, we asked respondents, who do you want making decisions for you about your care at the end of your life? Vast majority says they want a family member making these decisions. We then asked, have you talked with this person, whether it's a spouse or child, whoever they said they wanted their decision maker to be? Have you talked to this person about the kind of medical care you would want near the end of your life? 45% of all respondents say yes, virtually the same 42% that we found in 2011. So no change in talking to their preferred decision maker. 70% of older adults say they've talked to their preferred decision maker. White respondents, respondents in the highest income groups, more likely to say they've talked about their wishes than others. On the next slide, this is something we asked about, and it's a pretty key series, I think, in the survey, asking about what are people's preference, what do they want near the end of their life, what's important to them. This chart shows the percent, this was a 1 to 7 scale, the percent saying this is extremely important to me. And what we found, we even asked more than this, you can find it on the website, the whole series, but these are sort of some of the key factors that are important to people in the survey. So among the top really is not wanting to burden family, whether that's making sure my family isn't burdened financially by my care, burdened by making decisions about my care, burdened about taking care of me. And we heard that loud and clear in the qualitative research, by the way. So it's this feeling that's among the top, especially not burdening my family financially, not being able to pay for the care I need. Probably not a surprise given our current healthcare system. But those are sort of the top factors that people have, the top preferences people have and what they want, what's most important to them. And again, this is similar to what we found in 2011, this not wanting to burden family among the top factors for people. On the next slide, so there was general agreement on what those most important factors are across race, ethnicity, income, across a lot of demographics. But there were a few areas in which we do see some race and racial and ethnic differences. So Latino and Black respondents in the survey were particularly likely to prioritize being at peace spiritually. Again, this is the percent of these groups who say extremely important. The Black and Latino respondents more likely to say having doctors and nurses who will respect my cultural beliefs and values. Again, just a footnote, remember that the API, Asian Pacific Islander respondents were English only. Black and Latino respondents more likely to say it's important to live as long as possible and to be at home when they die. On the next slide, another finding that was consistent from 2011, which we were curious about whether there are any differences. If given a choice at the end of your life, where would you want to be when you die? 7 and 10 say at home. 71% in this survey, 2011, 70%, the same proportion. The next, the 15% say at a hospital, and then a smattering of other places. We did not ask people, you know, why is this your preference in the survey? We kind of heard some themes in the qualitative, but that we didn't ask in the survey. But 7 and 10 say the place they want to be when they die is at home. On the next slide, so where do deaths happen? This is from the CDC. The most recent data we have available is from 2017. And if you look at that second group of bar charts at home, so the dark blue, 36% of deaths in California in 2017 happened at home. So you can see that there's a gap there. 7 and 10 Californians want to die at home. 36% of deaths in 2017 actually happened at home. However, over the past several years, it seems to be slowly increasing, and that gap between perhaps what people want and what actually happens may be narrowing. On the next slide, so we've been talking about palliative care. Dr. Kinderman sort of defined it to level set with us all. We did explore preferences and whether people thought they were receiving palliative care, and there's a lot more in the survey, but I'm just going to read what we gave respondents and what they heard, and then I'll talk about what we found. So people, this was the question people got. Some people with a serious illness get extra help. This type of help is on top of regular medical care. It could be help with things like dealing with side effects or pain, dealing with stress or other hard feelings, figuring out how to live better with your illness, or finding out what services you might qualify for. Do you think you would want this type of help if you had a serious illness like cancer? Okay, 9 and 10 say yes. I would definitely or probably want this type of help if I had a serious illness. No differences by race, ethnicity, no real differences by income. Large majorities across groups say they would be interested in this type of help. On the next slide, we asked, again, we had 588 respondents who currently have a serious or are dealing with a serious illness. So we asked those respondents, gave them the same definition, and said, would you want this type of help to deal with your illness? Almost 8 and 10 say definitely yes, probably I would want this type of help. And then we also asked, do you already get this type of help? So among Californians with a serious illness in our sample, 41% say yes, I already get this type of help. 44% say no. So I'll leave it to experts on this call whether 41% is a big number or a small number or about right. But that's what we found. And what's really interesting as well is when we look at by income level, there's not a big difference here, at least not statistically significant. So in other words, higher income folks are not more likely to be receiving palliative care than lower income people. On the next slide, this question came from the qualitative research, and we heard people talk with a serious illness or caregivers talk about how they didn't feel they were getting as much information as they wanted to from healthcare providers, especially about what to expect in the near future and long term with their illness. We had people who said, the doctors just weren't talking about that, and we're focusing more on the day-to-day. So I don't know that this is not a perfect question, but it gives you a sense of where people are. We asked, if you had a serious illness, how much information would you want from your healthcare provider? Would you want as much information as possible about what I can expect now and in my future, or would you want just enough information to get me through day to day? Again, that language kind of came from the qualitative. So the vast majority of respondents want more information rather than less. And again, results are consistent across income, across race and ethnicity on this issue. Somewhat related, on the next slide, we asked, and again, based on the qualitative, and I'm sorry, I should have said that we're getting into the new questions from this survey. We asked, how prepared do you feel to deal with your illness if it gets worse in the future? So this is just among respondents with a serious illness. We asked this, how prepared? And then we said, by prepared, we mean you know what is going on, you can plan for what's coming, and you feel ready. So among all respondents with a serious illness, 17% say they feel very prepared. And there is an income difference here. 7% of those in the lowest income categories, under 150% of federal poverty level. And I should have said at the beginning, the federal poverty level for an individual is between 12 and 13,000. So that's 100% of the federal poverty level, about 12 to 13,000 for an individual. For a family of 4, the federal poverty level is, I think, 25 to 26,000. So that gives you a sense. So 150% of that and lower, only 7% say they feel very prepared. More than 3 times as many of the highest income groups say they feel prepared to deal with their illness if it progresses. The last slide I'll just go over again, and this came from insights from the qualitative research, is whether among respondents with a serious illness, what kind of supportive services, if any, do they need? This chart is segmented by income again, and I think that I feel like this picture sort of just jumps out at me. If you look at the orange bar, which is under 150% of federal poverty level, so people with a serious illness in California with the lowest incomes, and I guess it's not a surprise, quote unquote, but it's pretty, there's a lot of gaps here. So 7 in 10 or more say they need financial help or be helpful to pay bills just to make ends meet. 3/4 say it would be helpful to get help with pain or other side effects, get pills or medication sent to their home. We heard this a lot in the qualitative because transportation issues and time are such big issues, especially in California. Help paying for healthy food. Also, majorities of the lowest income groups and sizable proportion of other income groups say it'd be helpful to get assistance with sadness, stress, and other difficult emotions related to their disease. Having better and more affordable housing, obviously an issue, and then help with transportation. So I'm going to, and by the way, on this slide, there's an extra fact sheet on the website where we go more in depth on the extra support that low-income Californians with serious illness may need. So that's available. And I think I'm going to turn it back over to Kate, but just to remind everyone what Kate had mentioned, there's a full deck, full report on the website. There's detailed methodology on the website if you have questions, fact sheets, and sort of a storytelling tool on the website as well. So let me pass it back to Kate to talk about implications.
So I will jump in.
Yep,
Sorry, Tressa, thanks. So thanks for walking us through that, Tressa. So as a palliative care physician working in a safety net hospital in San Francisco, I wanted to talk about how these findings match up with what I'm seeing on a daily basis and what I hear from colleagues who are working particularly with vulnerable populations, since these populations were focal areas of our survey. So what do the survey results tell us? I love that the survey, at least the webinar title, is Help Wanted, in thinking about the proportion of people who say they would want the type of services that palliative care provides. The survey tells us, I think, about a number of challenges and opportunities, frankly, going forward. One of them is around communication, particularly between people who have a serious illness with their healthcare providers, being able to access the type of support that palliative care provides, and then the different levels of help that are needed for different populations. And you've already gotten a taste of that, but I just want to dig into that a little bit further. So one of the key findings is this gap between the desired and the actual communication that happens with people with serious illness. So what we found is that over 8 in 10 people said that they would probably or definitely want to talk to their doctor about their end-of-life wishes, but only about 1 in 5 actually had been asked about this by a doctor. And we know kind of from other studies that have gone on that there is sort of this both parties waiting for the other to bring it up, and then often it doesn't happen. We also saw that 92% of the people who responded said that they would want as much information as possible about what to expect as their illness progresses. And I think the thing that really popped out to me in that is that that finding was really persistent across all racial and ethnic groups. I think that sometimes there can be a perception that certain subpopulations do not want to hear information. And, you know, we do have the caveat that our Asian Pacific Islander sample is smaller, and those were English-speaking folks. But I think it's compelling that the vast majority of people really want to know. But these conversations are not always happening. So what's being done to address these communication gaps? Communication is desired, but it's not happening. And so there certainly are lots and lots of solutions that too numerous to go through on this webinar. But one suggestion, you can either work on the provider side and education, lots of work going on there. Another opportunity is to empower patients using tools that are appropriate. So one of those tools is a website called Prepare for Your Care. It's an online tool that's been tested in English and Spanish-speaking vulnerable adults. And what they found in using this approach to kind of empower and enable these behaviors is that using this tool compared to just an easy to read advanced directive was that there were higher engagement in advanced care planning behaviors, and there was an increase in the actual advanced care planning documentation in the medical record for the patients who were given the Prepare tool. So you can empower patients even without really working with the medical providers. Another key finding is that, unfortunately, people still don't know to ask for palliative care. We saw that just over 1/3 of the respondents said that they'd heard of palliative care, but 9 in 10 people said that they'd actually want the type of services that palliative care provides if they had a serious illness. But so how do they get these services if they don't know to ask for them? We know that Tressa talked about how the awareness of palliative care differs by income level. This is not a unique finding that we see here. There was a paper that was published this year in the Journal of Palliative Medicine that asked the same question around awareness of the term palliative care, and they found that there were significant differences based on education level and by race or ethnicity. So this suggests that there more opportunities are needed for people who are in less educated, lower income, and racial and ethnic minority communities in terms of raising awareness for palliative care. I wanted to highlight some of the excellent work that's being done in this space of trying to raise awareness, particularly among vulnerable communities. There are 2 organizations that are based here in the Bay Area, though certainly they have presented and talked about their work and made some of their tools available more broadly. One is the Chinese American Coalition for Compassionate Care, which helps to do community events and help healthcare professionals to understand cultural issues that come up for the Chinese American community and talking about serious illness and end-of-life care. The Alameda County Care Alliance is based here in the Bay Area also, and they have an excellent navigator program that's really networked through churches and is largely working with the African American community in the Bay Area to help them navigate serious illness and get the care they need. And then lastly, there's an organization that's based up in Oregon, Familias en Acción, which does a lot of similar work to the Chinese American Coalition with the Latinx community. The last key finding I wanted to dig into in some detail is that as income changes, it also changes what and how much people need. So we found that lower income respondents with a serious illness felt less prepared for when their disease progresses. So a third of people who are in the lowest income category versus 14% in the highest income category said that they felt unprepared. We know from research that's been done that low-income patients are more likely to present with advanced cancer. So when the cancer is first diagnosed, it is already widespread. We found at San Francisco General that actually a quarter of our cancer diagnoses are made in the hospital in an acute care setting, and that the disease is actually disproportionately stage 3 and stage 4 at time of diagnosis. And this is largely because a lot of folks who don't have good access to healthcare haven't been getting the preventive screenings and things that might have caught some of these cancers earlier. We also know that a lot of folks who have lower incomes have less financial cushion and work flexibility, particularly if they're working in day laboring jobs, and they just aren't able to have any savings if they're working really low wage jobs. I wanted to just briefly highlight a case example of this, a gentleman that I met just a few weeks ago in the hospital who has been going through treatment for metastatic cholangiocarcinoma, and he and his wife are primarily Spanish speaking. They rent an apartment here in San Francisco where everyone, I think, has probably heard about how high housing costs are in San Francisco. And his wife was not able to work anymore because she was now staying at home caring for him. And I heard in a very brief conversation with them how they started talking about selling their possessions to try to make rent since he couldn't get his disability insurance and his wife couldn't work. So, you know, in that situation, of course they feel unprepared because they don't have that financial cushion. Next, I wanted to just talk about this finding of kind of what people want based on their income level. So this is a question that was asked around what type of services do you think would be helpful for you if you were dealing with a serious illness. So when we look at the still low income, but the middle bracket in our study, we found that a lot of folks thought that all these different things would be important, from symptom management and conversations, information, spiritual support, and psychosocial support. When you looked at the highest income bracket in our sample, we found that far fewer of people said that they thought that these services would be helpful. And we'll dig into this in a little bit of detail. And particularly the largest gaps are around some of those psychosocial issues, things like paying for food, paying for housing, financial help. When you looked at the lowest income category in our sample, they said a lot of these things would be helpful for us, and particularly around these psychosocial needs that they have. Digging into this more explicitly around the items that they said would be really somewhat to very helpful, the number of proportion of people in these different income brackets where at least half of them said that these services would be somewhat or very helpful. If you look at the highest income bracket, they thought at least half of people said, yes, it would definitely be helpful to have help with pills or medications sent to my home. That was their number one. And then help with pain or other side effects. So these are definitely things that palliative care services can help people with. When you look at the middle income bracket in our sample, you see that there are a number of other items that pop up. And those new items that pop up when you look at that category are financial help to pay bills, help paying for healthy food, and help with sadness, stress, and other hard feelings. So that psychosocial bubble is getting bigger in this income bracket, but they also are talking really about the emotional, the existential, all of that kind of the spiritual component, I would say. When you look at the lowest income group in our sample, over half of the respondents said all 10 of the items that we asked about would be helpful. So they wanted help with everything. Their top item was financial help to pay the bills. So they're dealing with a serious illness, but they're, facing the situation that my cancer patient that I just spoke about, he's talking about, how do I make rent next month? So they want help with those basic day-to-day life needs, but also the other things like pain and symptom management, help with stress and sadness, and spiritual support. To flesh this out a little bit more with another brief case example, I'm going to talk about another patient that I recently took care of. I'm going to call her Casey. That's not her real name, and this is not a real picture of her. It's someone who reminded me of her. She was a middle-aged woman who lived in an apartment in San Francisco and came in with complaints of headache and some nausea, and we found, unfortunately, that she had a widely metastatic, poorly differentiated adenocarcinoma. It was so aggressive and advanced that we actually couldn't even tell where it had started from. We thought maybe her lung, but we weren't sure. And the reason she was having all the symptoms she came in with was because she had a metastasis in her brain that was causing pressure and contributing to all of these symptoms. So when our team was called, the plan was to actually do brain surgery to remove this metastasis. She also had longstanding kidney disease, and there had been previous documentation that she had said she wouldn't want dialysis. And as her body was going under more stress, there was some concern around whether or not she would be faced with full kidney failure and whether she would need dialysis. And then finally, from the team's perspective, they were concerned about pain control in someone who has a history of opioid use disorder. So those were the things really that the team was thinking about and that they called us about. But the things that Casey was actually worried about were the things below this line. She was worried about what is going to happen. How is my roommate going to take this? How is he going to handle this news? And what's going to happen if I can't take care of myself? She was worried about the fact that her landlord had said that her rent was going to go up, and then she would be facing a serious illness or the end of her life on the streets. So she was focused again and again as I talked to her on this. And then the last thing that really mattered to her was what was going to happen to her dog if she was no longer able to take care of him. So I just say this to highlight there's often a difference between what the medical teams are concerned about and what is most important. In this case, for someone who is a lower income, vulnerable person, her priorities were much more alongside the psychosocial issues and much less so what's going to happen to me with my treatment. So I'll just spend a couple minutes here talking about, we referred Casey for services at home, and that was really made possible by legislation in California that expanded access to palliative care for Medicaid beneficiaries. So that mandates that people with advanced cancer, lung disease, heart failure, and liver disease have to have access to palliative care. And the way that the state kind of worked this out is for the state felt that early palliative care is important, it's necessary, but the area that we're actually mandating access to palliative care is for people who have likely a prognosis of 1 year or less. They can still be pursuing disease-modifying therapy, but they can get all the extra support of palliative care as well. Since we're talking about how to improve care for people who are in these vulnerable populations, I'll talk a little bit about what it's been like as different programs are trying to implement SB 1004 in California. what we found from this experience is that patients who are getting Medicaid, who are eligible for these services, can actually be really hard to engage. They may get contact information for this patient, but the phone line has been disconnected, so they can't reach them, or the address has changed. And so just even making contact is really challenging. It's helpful if once you even make contact to really leverage trusting relationships with either a case manager or a primary care physician or a specialty physician or someone else who knows the patient who can recommend the service. Because if you're someone who's getting cold called by someone else, new organization, you may be skeptical about who they are. And lastly, the palliative care teams that are trying to implement these services are really facing lots of high psychosocial needs. How people have responded to this is to make sure that they have social workers on their teams, and they're partnering with the health plans and community organizations that help provide these necessary social services. One emblematic quote from a palliative care group trying to implement SB 1004 is that you need to address their immediate needs, whatever they may be. That's often not traditional palliative care stuff, but this leads back to palliative care support and services once you've built that trust and you've addressed the immediate needs. I will end by just saying I think that this survey really calls us to think about what do we do to improve care for vulnerable Californians. We need to really think about how to improve the quality and timing of communication that happens, particularly looking at the impact of bias by race and ethnicity, as well as income, which isn't really talked about as much in the literature. We need to develop strategies to inform specifically vulnerable communities about the benefits of palliative care, and I would say also emphasizing that palliative care includes the psychosocial assistance. We need to address access gaps that in some states may be about implementing policy for vulnerable communities. In California, we're really focused on the logistics of how we implement, and in some cases it's both. And lastly, palliative care programs that serve vulnerable communities really need to invest in partnerships in the community and other organizations that go beyond typical palliative care team scope. So with that, I wanted to make sure that we had time for questions.
Thank you so much, Dr. Kinderman and Tressa. Really appreciate both of your time and expertise on the call. So we do have about 13 minutes or so before the end of our webinar today to answer any questions that folks may have. So please go ahead if you do have a question and type it into the question and answer functionality within the webinar. We do have a couple in here that we can start with as others who may have questions type theirs in. So the first was a specific question, this is for Tressa, about one of the data points cited in the survey results today. The question was, were you able to look at the results for, are you getting this type of help already? The question that alluded to the kinds of services typically provided by palliative care. Were you able to look at those results by race and ethnicity?
Yes, so we did look at that. We could look at white, Latino, and Black respondents. We did not have a large enough sample size because remember this question was among just respondents who have a serious illness. We did not have a large enough API cell size there. But this was, again, another surprise. To me, personally, a little bit of a surprise because we did not find racial income differences on this question, nor did we find racial differences. And in fact, the margin of error here is big because these are subgroups, but to give you an example, 40% of white respondents with a serious illness say they're getting this type of care. 48% of Latino respondents with a serious illness say they're getting this type of care, as well as 47% of Black respondents with a serious illness. So if anything, respondents of color are slightly more likely to say they're getting this type of care, but statistically, I wouldn't call that a difference.
Thank you, Tressa. All right, we have a few questions in here, and we'll see how many we can get to. So one question, I think this is probably for you, Anne, and based on your kind of understanding of your own program and other programs as well. Have you or are you aware of other programs that have incorporated the use of community health workers with a disadvantaged population? And if so, what might you be able to share about that type of experience or the value that that type of team member can add?
Yeah, for sure. I think we actually, our program is actively recruiting for a hopefully bilingual, bicultural Spanish-speaking patient navigator and also a Chinese-speaking patient navigator. And the reason why we wanted to bring on those folks to help really coordinate care and reach our communities is because, you know, I think there's a lot of literature around kind of more peer-oriented navigators, people who come from a similar community, to get at this issue that I brought up in the kind of the challenges of implementing SB 1004, that there's a lot of mistrust around what are you talking about and what are these services, and am I giving anything up, or, you know, what does this mean for me? So we're, I think, thinking about this as a way to address those disparities. And I know that there's some palliative care programs that actually also use their navigators to do community outreach and education that are more able to communicate with certain vulnerable communities than it would be for me to do the same work.
Thank you, Anne. There's a couple of questions that have to do with, I think, the engagement of appropriate patients into palliative care services. So I'll kind of bundle those into one question. One is a recognition that some of the points raised around the call to action towards the end talked about the patient population, but didn't necessarily talk explicitly about engaging physicians to refer to palliative care. So I think there was an interest from one of our attendees to hear your perspective, Anne, on appropriate ways in which we as a field can do a better job of engaging referring physicians and helping them to understand both the needs that patients are expressing and the opportunities offered by palliative care.
Yeah, that was certainly another one of the challenges that people have experienced in implementing SB 1004 in California, is that there are a lot of misperceptions around what palliative care is. And organizations that are trying to implement these programs and just make sure that the people who are eligible can actually get them, is that there's skepticism or misunderstanding. And so there's certainly a lot of work to be done with educating providers around what palliative care is. Though I will say, you know, I've been working here at San Francisco General for 10 years, and that still comes up on a daily basis, even though it's you know, a reasonably sized hospital where you think we could get through. I think it's that when healthcare professionals in particular have a misperception, it's really hard to shake. So I think where there is an opportunity that we found, the California Healthcare Foundation supported some research in Southern California around Medicaid providers, whether they knew about SB 1004 and knew about these services, and a lot of folks didn't. So I think that there's certainly more work to be done, kind of thinking about federally qualified health centers and folks who really need a lot of help taking care of very high need populations. I think palliative care could actually be a win-win situation if we can let people know that it's available.
Thank you, Anne. I think sort of related to these same concepts, this is a question we hear come up occasionally on webinars such as this, but one person wondered, and is interested in your perspective, Anne, on the idea of use of the term palliative care versus use of the term supportive care services, and whether what your thinking is on how much these words matter, and anything related to how you can talk about these services with patients and families in ways that help them truly understand them. Yeah,
you know, there is a whole more than a decade of discussion about this in the palliative care world about whether or not that name should be changed and whether particular palliative care programs call themselves a palliative care program or whether they call themselves something totally different. So, for example, our colleagues at UCSF, their outpatient palliative care clinic is called the Symptom Management Service. We actually, our inpatient program is called Supportive and Palliative Care. Our outpatient clinic is called the Plus Clinic. And we really deliberately used that name to try to re-emphasize this idea that palliative care is an extra layer of support, that it's not an either or, it's oncology care plus, or liver clinic plus. So I think that there are heated debates about this, about whether it's best to continue with palliative care as the name and just focus on education, or try a different tack. And I will say, from my perspective, working in a safety net hospital, we talked about how the awareness of the terminology of palliative care is still, we have a lot of work to do. But even when you look at low income, lower educated, and racial ethnic minority communities, far fewer of those folks actually have heard of palliative care. So my experience is that it's actually a blank slate when I come to people and I talk about palliative care. And so I usually say, hi, my name is Dr. Kinderman. I work with a palliative care team. Have you ever heard of palliative care before? And when they say no, I say, that's very common, and here's what it is. And then there's never, hardly ever any concern around the services that I'm offering, because people 9 in 10 say that they want it.
Thank you, Anne. So one other question, I think we probably have time for about 2 more questions, so I'm just going to preview that I'm not going to get to all of the questions that have been typed in, but we will try to respond offline to those whose names we can see on some of the questions that we don't get to. But one question I thought might be important to the full audience to hear. One attendee asked, please share the importance, or what you see as the importance of trained medical interpreters at the bedside versus a family interpreter. Anne.
Oh, goodness. Yes. So we always work with professional interpreters, and the access to professional interpreters is actually required by law for any organizations that take federal or state funding, which is basically almost all healthcare organizations. And I will say we sometimes have been in situations where we are we need to ask for a staff member who kind of has passed a test that they're bilingual. It is a completely different experience working with a trained professional interpreter versus someone who is not trained specifically as an interpreter. And then if you go the extra layer of actually putting the burden of not just processing the information and being present as a family member, but also the burden of, translating complicated medical terms and concepts. It's really too much, in my opinion, to ask a family members to act as the interpreter in those situations. I'm aware that that type of thing happens, but it would certainly not be my recommendation.
Thank you, Anne. So we have time for just one last question. And again, apologies for those we didn't get to. We will follow up offline as long as your name is visible on the webinar. If not, you can email me. The question is for you, Anne. Did any of the survey findings, so you've only had a week or 10 days to digest them, did any of the survey findings make you think of ways you might change your own program? Is there anything that you observe that is making you think about process changes or service changes?
Yeah, it's a great question. I think the survey findings I find are really important to give us a point of reference around the disparities that exist, the challenges and the opportunities that exist. I will say that as someone working with this population as my 100% my clinical setting, none of the findings particularly surprised me. I will say that the most surprising piece was, as I highlighted, that really all across all racial ethnic groups, everyone said that they wanted as much information as possible. And I have run into family members where they say, you know, please don't tell mom about what's going on because that would worry her, et cetera. So I don't think personally, we certainly focus a lot, as I mentioned, you know, having social workers on our teams is absolutely critical. And we actually are moving into having patient navigators because of these, to try to bridge these cultural and linguistic divides a little bit better.
Thank you very much, Anne and Tressa, again, for your time today. And that brings us to the close of this webinar. I just want to thank everyone for attending and encourage you, please, to take some time to look through the full information and resources available on our website, the data snapshot, the fact sheets, the videos, and please share them widely with your networks so that we can help get this important information out into the world. With that, hope you all have a good afternoon, and thank you so much.